Welcome back guys. Now let's continue with the distal convoluted tubule. Already we have discussed about the PCT, loop of Henle completed, now DCT. Now in DCT, what exactly is happening? See, any water is reabsorbed in the DCT? First of all answer, no. There is no water reabsorption in the DCT. Then what is happening? Solutes are getting reabsorbed. First look at here, this is the side of the lumen. Okay, here is the lumen side. Try to understand, this is the side where the urine is passing like this. Okay, the urine is passing through the DCT. Now, look at here, there are two transporters which are present on the luminal membrane. See, on this luminal membrane, or you can say the apical membrane, two transporters are present. What are these two transporters doing? See, the transporter number 1, this one, it is trying to reabsorb sodium and chloride. It is reabsorbing sodium and chloride. So what is the name of this transporter? You can call it as sodium chloride importer. This is not NCC. NCC is different. That is sodium potassium 2 chloride is different. This is just sodium chloride importer. Okay. Next step. This transporter which is helping in the reabsorption of calcium. This transporter is called as a TRPV5 channel. Okay, TRPV5 calcium channel. Transient receptor potential vanilloid calcium channel number 5. Two channels are there. Next step. On the basolateral membrane. See, on this basolateral membrane, again two transporters are there. What are these two transporters doing? See, one is trying to throw 3 sodium ions out of the cell. Okay, one is trying to remove 3 sodium ions out of the cell and bringing 2 potassium into the cell. We all know it's our favorite sodium potassium pump. Next, the fourth transporter, look what it is doing. It is bringing sodium into the cell in exchange for the calcium, into the blood. So now the fourth transporter, which is very important for your exams, that is sodium calcium antiporter, or you can say sodium calcium exchanger, because exchanging one sodium ion for calcium ion. Done. So these are the 4 transporters present. So here anywhere have I discussed with you water is getting reabsorbed? No. So from the urine, who is getting reabsorbed? Sodium, chloride, calcium. These are the 3 things which are getting reabsorbed. So now write in the DCT how many types of transporters are there? 4. What are they quickly? One is sodium chloride importer. Next, TRP V5 calcium channel, sodium potassium pump, and sodium calcium exchanger. Okay, these are the 4 transporters which are present. Now I am asking you, tell me, in how many ways sodium is coming into the cell? Okay, the intracellular sodium levels are maintained by how many transporters? So the intracellular sodium levels, look at here, this is the one way by which sodium is coming to the cell, and this is the other way by which the sodium is coming to the cell. So tell me, in how many ways sodium is coming to the cell? 2 ways. So the intracellular sodium levels are maintained by these 2 transporters, bringing sodium into the cell. And whatever the sodium that is coming into the cell, the sodium will go out with the help of the sodium potassium pump. You all know this. So these 2 transporters are supplying the sodium to the sodium potassium pump. So the sodium potassium pump is kept on working and the cells are living. Okay, cells are living happily. Now today, what am I doing? Listen carefully. I am blocking this transporter number 1. That is sodium chloride importer blocker with the help of a drug called as Thiazide diuretic. Thiazide. So now tell me, Thiazide diuretics block, sodium chloride importer. Loop diuretics block, NCC, Thiazide diuretic block, sodium chloride importer. Loop diuretics acts on TAL, thick ascending limb of loop of Henle, but the Thiazide diuretics acts on DCT. So you tell me, if I use this diuretic called as Thiazide diuretic, sodium chloride importer inhibited. So sodium loss, chloride loss into the urine, sodium chloride loss into the urine. Wherever sodium chloride goes, water follows. So polyuria, or you can say diuresis. Okay. So blood volume decreases, blood pressure decreases. So usually Thiazide diuretics will cause the sodium chloride loss out of the body, leading to excessive urination, so that our blood volume decrease, our BP will decrease. So Thiazide diuretics are used for the treatment of hypertension. These are anti-hypertensive drugs. Okay, Thiazide diuretics. That's fine, sir. But look here, the day I use a Thiazide diuretic, this transporter is blocked. Fine. So now tell me, do you think sodium is going to the cell? No, sodium is not going to the cell, guys. Now, what happened to the intracellular sodium levels? It decreases. So sodium is not available for the sodium potassium pump now. So it will stop working. So cells can undergo death. What I am trying to say, the day you block this transporter, the intracellular sodium levels will go down. Is that good? I am asking you? No. In order to maintain the sodium levels, Now who should work more in order to maintain the sodium levels? Now the sodium calcium exchanges has to work more because now it has to bring more sodium into the cell. Now while trying to bring more sodium into the cell, listen carefully, while trying to bring more sodium into the cell, it has to exchange more calcium. Okay, it has to exchange more calcium into the blood. So thiazide diuretics, the day you use thiazide diuretics, which transporters will function more? The sodium calcium exchangers will work more. Now when the sodium calcium exchanger is working more calcium will be reabsorbed, Okay, understood? So now tell me, loop diuretics I have explained you. Loop diuretics loses the calcium out of the body. Loop diuretics causes calcium loss, magnesium loss. But what about the thiazide diuretics? If you use a thiazide diuretic, the sodium calcium exchangers will work more. So more calcium will be exchanged, or more calcium will be reabsorbed into the blood. So let's write all these points one by one. Okay. So thiazide diuretics increases calcium reabsorption, but loop diuretics causes calcium excretion out of the body. Next, guys, there is a hormone called as a parathyroid hormone. Now, where do you think this parathyroid hormone will act? It acts on PCT as well as DCT also. But when the parathyroid hormone is acting on DCT, it increases the number of the sodium calcium exchangers. So tell me, parathyroid hormone, what it will do? It increases the number of sodium calcium exchangers. So more calcium will be reabsorbed. Simple logic, no? More calcium will be reabsorbed. So now tell me, parathyroid hormone acts on DCT, increases the number of the sodium calcium exchangers, so increasing the calcium reabsorption. So right. So the calcium reabsorption is regulated by which hormone? Parathyroid hormone. What PTH will do? Parathyroid hormone creates more number of sodium calcium exchangers. So more calcium will be reabsorbed. Done. Now let's go into little pharma and medicine integration. Guys, the sodium chloride symporter, it is blocked by which diuretics? You already know. Thiazides. Okay, thiazide diuretics. But what if the same sodium chloride symporter, what if the same sodium chloride symporter is mutated from the birth itself? Time bad in this guy. The sodium chloride symporter is getting mutated. Now that's going to cause a disease called as a Gitelman syndrome. So now in both these conditions, look, that is the person who is on thiazide diuretic usage and the person who is suffering with Gitelman syndrome, it is the same transporter that is getting affected, same sodium chloride symporter. So in both these conditions, the clinical features will be same. The Gitelman syndrome resembles which diuretic usage? Thiazide diuretic usage, because in both the conditions, it's the same transporter getting affected. So similar clinical features, sodium loss, chloride loss, polyuria, same things. So right, Gitelman syndrome, autosomal recessive disorder. Okay, it's autosomal recessive disorder. Defect in which part of the nephron? Defect in DCT. DCT defect. Which transporter defect? Sodium chloride symporter defect. Think about the Bartter syndrome. Bartter also autosomal recessive disorder. Bartter is a defect in TAL. Bartter is a defect in NCC transporter. Okay. Next, Gitelman syndrome resembles thiazide diuretic usage. Thiazide diuretic overusage. Okay. Next, what else you have to know? So in this condition, there is sodium chloride loss. Okay, sodium chloride loss. Okay, when compared to Bartter, Gitelman is like a mild variant. Bartter, there is more sodium chloride loss, but here there is less sodium chloride loss. Okay, but at the end of the day, because of the mutation of the sodium chloride symporter, sodium chloride loss. Okay, sodium chloride loss. So what happened to the sodium levels in the body? Decreases. Don't forget, the sodium levels are decreasing. Now, because of the sodium chloride loss, there will be dehydration. Whenever the person is getting dehydrated, there will be hypotension. Okay, there will be hypotension because sodium loss, water loss, polyuria leading to dehydration and hypotension. So now my patient is having hypotension. So you tell me, whenever a person is having hypotension and hyponatremia, sodium levels decreases and BP decreases. Which pathway is going to be activated? Now there is RAS activation. Now RAS pathway activated. Now what this RAS pathway will do? RAS pathway helps in the production of aldosterone. Okay, aldosterone. Now have I already taught you aldosterone? What it will try to do? Aldosterone decreases your potassium. Aldosterone decreases your acid. Okay, aldosterone decreases the H plus and decreases the potassium. Aldosterone, while trying to increase the BP, while trying to increase the sodium, that will do. But anyway, because of this aldosterone, what will happen to the potassium and acid? There will be hypokalemia. Okay, hypokalemia, and there will be metabolic alkalosis. Okay, there will be metabolic alkalosis. So now, what are the clinical features? The patient with the Gitelman syndrome is going to present with hypotension with a hypokalemic alkalosis. Similar, right? Exactly where we have seen hypotension with a hypokalemic alkalosis. Just go back and look at the Barter. In Barter also, I have told you, see hypotension with a hypokalemic alkalosis. Exactly the same. Exactly here also, the Gitelman syndrome babies are also going to suffer with same hypotension with a hypokalemic alkalosis. These babies are severely dehydrated. Because of this dehydration, there may be a sunken anterior fontanelle can be seen. Okay, so same things. But how it is different? In Barter there is deafness. In Barter there is calcium loss. In Barter there is renal rickets. In Barter there are kidney stones. But here no such things are there. So what else you have to know in the Gitelman syndrome? See, in Gitelman syndrome, to their bad luck, one more transporter is defective. The transporter is TRPM6 magnesium channel. So this TRPM6 magnesium channel is defective, which is going to cause severe hypomagnesemia. So their magnesium levels are going to be very, very less. So there is severe hypomagnesemia, guys. So in these fellows, there is severe hypomagnesemia. There it is severe hypocalcemia. Barter is the main calcium loss. Gitelman is main magnesium loss. So in these babies, okay, with the Gitelman, not only the sodium chloride importer is defective, to their bad luck, one more transporter is defective, that is TRPM6. So magnesium levels are also going to be very, very, very less. So these are the important points which you have to know regarding the Gitelman syndrome. Done. Next, having said that, let's see the differences between the PCT and DCT, and let's wrap up this topic. Guys, look, PCT, we all know there is brush border epithelium. In PCT, there is brush border epithelium. Brush border epithelium. Okay, if you look at the PCT, let's say here is the PCT, guys. Now, what kind of epithelium is present? That epithelium is having the brush border epithelium, and there are gaps between the epithelial cells. Okay, and there are also gaps between the epithelial cells. But if you look at the DCT, how the DCT is going to be? The DCT cells, they are not having any brush border. The two, these cells are tightly attached with one another. Okay, there are no gaps, right? No brush border. Okay, no brush border. Next up, because of these gaps, what is the importance of these gaps? Through these gaps, water can be reabsorbed. Through these gaps, water can be reabsorbed. So there is paracellular, means in between the cells. Para means in between the cells. There is paracellular water reabsorption. Okay, there is paracellular water reabsorption possible in the PCT. But in DCT, there is no water reabsorption at all because of the presence of tight junctions. Okay, in between the cells, there is there are no gaps. There are tight junctions. So there is no water reabsorption. Okay, there is no water reabsorption at all. Next, any other difference between the PCT and DCT? Okay, any other difference between PCT and DCT? Try to understand, guys. PCT is rich in carbonic and an enzyme called as carbonic anhydrase. Later I will explain you in the topic of the acid-base balance. In the PCT, there is this enzyme called as a carbonic anhydrase type 2 as well as type 4. Both carbonic anhydrase type 2 as well as type 4 present. Both are present, which will help in the bicarbonate reabsorption. Carbonic anhydrases in the PCT helps in the bicarbonate reabsorption. But in DCT, yes, carbonic anhydrase is present, but only type 2. Okay, only type 2. So with this, what we have completed, we have seen the differences between the PCT and DCT. We have also discussed about the Gitelman syndrome. Okay, we have seen the mechanism of action of the thiazide diuretics, the site of action of the thiazide diuretics, and the distal convoluted tubule. So now you tell me, distal convoluted tubule, there is no water reabsorption at all. Okay, there is no water reabsorption at all. So the urine will be diluted or concentrated. What do you think? There is no water reabsorption, only solutes. You are removing the solutes out of the urine, right? First, okay, let me give you the clarity. Let's say this is ascending limb of loop of Henle. In ascending limb of loop of Henle, what is happening, guys? Look, in the ascending limb of loop of Henle, you are removing the solutes. As you are removing the solutes, the urine is kept on getting diluted. But in the, let's see the extension here. In the distal convoluted tubule, okay, let me draw the extension here. In the distal convoluted tubule, again, who is getting reabsorbed? It is the sodium, chloride, calcium. So you are reabsorbing. Okay, solutes. Again, as the solutes are getting reabsorbed, what do you think will happen to the urine? Urine is getting further diluted from 100 to 90, 80, 70, something like that. So even the distal convoluted tubule is going to cause the dilution of urine. Dilution of urine. But main diluting segment is the ascending limb of loop of Henle. Okay, the urine is getting diluted from almost 1200 to 100. But even DCT, the point what I am trying to say, the urine is getting further diluted from 100 to 95, 90, 80, 70, something like that. So distal convoluted tubule also dilution. Ascending limb of loop of Henle is also dilution. In the descending limb of loop of Henle, urine concentration. In the PCT, isotonic to plasma. In the PCT, the urine is neither getting concentrated nor diluted, isotonic to plasma. Descending limb of loop of Henle, urine is getting concentrated. Ascending limb of loop of Henle, urine is getting diluted. Distal convoluted tubule, diluted. Okay, so let's see what happens in the collecting ducts later. Hope the video is helpful. Thank you.